All right, Kevin, we are ready to go.
Okay, great. Well, good morning, everybody. Thank you for joining us for the March 2nd, 2022 Health and Wellness Committee meeting. I think it's the 61st day of the year. It's hard to believe we've been through that much of 2022, but remember last meeting was Groundhog Day. Punxsutawney Phil probably didn't get it right for our area because forecasted high is 76 degrees today. Azaleas are blooming. Things are starting to look like springtime out there. Since we met last time, we had a record-breaking crowd in Charleston for SeaWee, and of course, today's Ash Wednesday, the beginning of the Lenten season, and it's also Read America Day, and of course, St. Patrick's Day just around the corner. And Paul would tell you that those of you training for the Cooper River Bridge Run, we are exactly 1 month away from the Cooper River Bridge Run happening on April 2nd. So anyway, just want to welcome you and tell you thank you for joining. And I'll make a motion that we approve the minutes from that February 2nd meeting. Can I get a second?
Second.
Okay, thank you, Dr. Andrews. Okay, the minutes have been approved. We've got a busy schedule today, so I'm going to jump right into it. We're going to start off with, most of you know Joey Current, the health program manager for Trident United Way, and Joey's going to be leading us through a great presentation about some the disparities in life expectancy and some things that we've been talking about. But I'm excited to hear from Joey. So Joey, if you would take it away from there.
Sure. Thank you so much for the opportunity to come speak. So for folks who have been on these calls, you know that as a group, we have all been looking at the life expectancy data that comes from DHEC around our region. And so to continue that conversation and to maybe have some discussion about what next step we might take to address these disparities, I thought I would put together a short presentation for this group. And so I'm going to share my screen and pull this up. And then let's see what happens when I do this. All right. So the question is, are you seeing the full slide or are you seeing the presenter mode?
We see both. Yeah, we see the presenter mode.
Presenter mode.
Yeah,
okay, hang on one second. Let's see if I can fix it. Let's do this.
Yeah, that's better, Joey. That's great.
That's better. All right, great. So you guys should just be seeing the slide itself. Fantastic. So today we're going to talk about addressing disparities in life expectancy. Just as a note, in general, where we live makes a difference on how well and how long we live. We know that not everyone has the same opportunity to be healthy where they live because as we've seen data, specifically the life expectancy at birth data that we've seen show folks who are living just a few miles apart that have vastly different health outcomes. All right, so this is our familiar map of life expectancy. This comes from the City Health dashboard. We have similar maps that have come directly from DHEC that we've looked at, which show the same things. That are the darker areas of blue that you see in this map are zip codes and census tracts where the average life expectancy is much lower on average than the lighter zip codes and census tracts that you can see here. I have pointed out a few of those of the worst zip codes in red with red arrows here on the map. And then you can see some of those right next to those zip codes, in some cases, literally right across the river, where we have some of the highest data and some of the highest rates of life expectancy. So this is the contrast that we're looking at. These are the disparities that we're hoping to address. And once again, you can see in some cases, the gap in life expectancy is more than 10 years. So then the next logical question would be, what are the leading causes of these disparities. And what we look at to find that out, we look at our leading causes of what is known as premature death. So in South Carolina last year, this data comes from the National Center for Health Statistics. We can see that when we look at the leading causes of premature death, we see things like traffic fatalities, we see chronic disease, we see cancer, we see infant mortality, and then we have gun violence and suicide in there as well. So these are all of the leading causes of premature death. Once again, premature death is a measure of years of potential life lost due to death occurring before the age of 75. So then the next question we have to ask is, what are the factors that impact these causes of premature death? And you might be surprised to know that of all the factors that affect premature death, healthcare, the care that we receive when we go to the hospital or to a clinic, only accounts for about 10% of the risk for these premature deaths. And so we see that genetics obviously plays some part, and there's not a whole lot that we can do about that. But then you see this 60%, more than half of the risk factors for premature death come from our individual behaviors and the social and environmental factors or the environment that we live in. And so the diagram on the right just basically gives you a description of what are called upstream and downstream factors. So downstream factors are the things that we are looking at, like life expectancy, infant mortality. But then when we start looking more upstream at what factors may cause those things, we see things like communicable disease, chronic disease, and injury, which we saw earlier as the leading causes of premature death. And if we look even further upstream from that, then what causes those things? Well, we have risk behaviors, which we've already mentioned: smoking, physical activity, things like that. And then if we move even further upstream, what can be affecting those behaviors? Well, we have people's living conditions. And the whole point of this diagram here on the right is to basically outline how we might want to move upstream when we look for ways to address these health disparities. And they can come in a variety of forms. So individual health education and behavior, those would be a lot of times the programs that we support that our organizations and government offers to folks. Those programs can affect people's knowledge, skills, and attitudes. Those can affect those health behaviors. And then we have policy change that can really affect policies, systems, and environments. So how do we accomplish this? Several of the members of this committee have come together and looked at a framework which can help us address these disparities in life expectancy. And this framework is called the Health in All Policies Framework. There are 5 elements that make this up. And what we would strive to do as a group would be to promote health equity and sustainability, support intersectoral collaboration. We want to benefit multiple partners when we're doing this work, engage external stakeholders, which I would have to say this group has done a fantastic job of doing, and create structural or process change. So how then might we prioritize what we want to focus on? Well, there's a whole list of mutually beneficial, collaborative ways that we can establish these priorities. But of course, we have to consider the cost, effectiveness, feasibility, and honestly, what things our city has power over. And then, of course, we want to consider what the magnitude of those health impacts are. So I've listed just a few examples. Education and information being one way we can do that. An example might be incorporating messages around the importance of physical activity and promotional materials for our parks. A guidance or best practice might be incorporating strategies that promote community health into comprehensive land use, which we've already done some of with our comprehensive plan. And there are other examples in there too. There are ways that we can affect this change through permitting and licensing, through regulation, through legislation, ordinances, and so on. So there are lots of ways that we can do this. And it really is all about what works best and how we can work collaboratively with our partners who are already doing this work. So as I mentioned, we have already done some pre-work here to try to incorporate health and wellness in our comprehensive plan. That would be one of the tools that we have in our tool belt to try to address these health disparities. And so I've listed out on the screen a few of those places where in the city plan, we have incorporated our health and all policies approach. You can see that it mostly focuses around transportation and built environment at this time, although we do have some opportunities built into our city plan to promote things like community gardens and addressing food deserts. And then we have some environmental health peppered in there as well, looking at the effects of extreme heat. So at this point, I'm going to turn it back over to Paul because we had talked previously that, in having this conversation and laying the groundwork for, what we might want to do, how we might want to prioritize our work and what steps we've already taken, it would be a good time for us to kind of talk about what partners we have around the table and within the city that might help us to address some of these causes of premature death. So Paul, I'll turn it over to you.
Oh, you're on mute. I don't know if you're trying to speak yet.
Thanks, Joe. We wanted to, we started with this discussion of getting the wheels back on the ground for us to really start to determine. The mayor wanted us to have some specific metrics. And as we look at life expectancy and those zip codes that you showed, the 29405, 403, 29407, where the low areas were in certain census tracts. And I can't remember, did you show what you did on your second slide? You showed what some of those metrics were of where the numbers were. When we initially were talking back in November, we were talking about 3 specific areas that we thought were going to be the leading areas that we should focus on. And they were around the food desert areas that we could look at different policies with, that we were looking, and I'm glad Nick is on here with the Low Country Food Bank, that maybe we'll have some more to add in. But we were looking at food deserts in these locations where the numbers were low. We were looking at access to health care and how where our resources are located, how are we making sure people are getting access. And then we were looking at our built environment. What are our parks and recreation? What are our connectivity? What does our transportation around those areas look like? So I don't know that we've come down specifically with exactly what those numbers look like and where we're going to drill down to start the measurement on everything. But I just wanted to open those conversations. Is that just to see what the feeling is around our committee, what we're recommending here to are we still on that course? Do we need more metrics to look at, specific ones? I just wanted to see how y'all wanted, what kind of direction y'all wanted to head toward in that discussion.
Hey, Paul, this is Councilwoman Parker.
Hey, Karen.
Hey, so I'm not a part of this committee. I'm just joining out of just sheer, this is obviously near and dear to my heart, and Parks and Rec is near and dear to my heart as well. But so I know for me, one thing to answer your question, again, I'm not a part of this committee, but you talk about connectivity to parks and recreation. I mean, this is certainly something that I'm dealing with in my community. and something that I hope to work on in the future is the fact that, half of my island, part of my district, we don't have sidewalks, walkways, bike paths, buses, transportation that can get some of these children to our recreation center. So I know if you're looking for a place, you're asking if you need more metrics or things like that, but I think you can look district in specific districts. Maybe Kevin can speak the same about his district. And, that's something I've also heard from constituents is, they don't have a way of getting their kids to the rec fields, to participate in some of these things. So that's just kind of one thought.
Yeah, thank you, Councilmember Parker. I will tell you some of what happens in my district. I'm sure it's similar in the district that you represent, is that not everything is city, or maybe things were built and then annexed into the city. And we're finding that things that were built maybe in your case in the town of James Island, but maybe not in the city of Charleston, may not have the sidewalk structures, and maybe it's been annexed in. But I find that a lot of times in the district that I represent, that where there's not sidewalks and places like that, were places that either still are not in the city or were built outside of the city and annexed in. But yeah, it's certainly an issue in parts of the district that I represent as well, having access to sidewalks and bikeways and paths and things like that.
Yeah, and one thing that I'm hoping to, whether it's private sector, I know I'm not sure exactly what y'all are working on as far as having the city get involved, but whether it's city-wide buses that can help get these children, to the fields. I know my son participated with a football team that, offered rides to and from the games, because obviously all of these parents couldn't get their kids to and from the games. Now that was all done, I think, privately through churches and, but we have the option of doing that. I'm just hoping for the city's support, getting some of these children and some of these constituents in parts of my district that, either have, are a lot of what I heard of are single moms, who can't get their kids to and from practice, things like that. So I'm hoping as a community that we can help work on that in my district. I don't know how much the city is going to be able to get involved, but that's just one thought, again, just because I saw it on the slide.
Yeah, sure. And that's certainly something that we can bring to traffic and transportation, parks and recreation committees, and certainly work on that. It has been a discussion in the past in some areas, but yeah, we can bring that, bring that to those committees, which will of course roll right into city council as well.
Right. Okay. Sorry to jump in on your committee.
No.
Just wanted to, there was a quiet, so I figured I'd jump in.
Thank you for joining in, and we hope that you'll continue to to be on this committee. I know that you were on the last one, and I hope you'll continue to join us. So thank you.
I just wanted to jump in. Joey, thank you for that presentation. I noticed you mentioned both gun violence and suicide. So just some real sort of practical low-hanging fruit things on the intervention side. I was just texting with Dr. Ashley Hink, who leads the hospital-based violence intervention program at MUSC, and they are forming an external stakeholders committee, and they would really like a representative from the mayor's office to be on that committee. And I think that could be a really great way to bring visibility to the work that's happening at MUSC. So I think that's one easy thing we could do. And the other thing related to both gun violence and suicide would be some way for the city to promote a public education campaign about secure firearm storage, because we know that is a significant driver of adolescent suicide and those unintentional firearm injuries among children.
I think those are great ideas. Thank you, Annie. And that just brought to mind to me that maybe a next step is having some of the departments that Representative Shealy was talking about come and address what measures or what they might already be doing or be planning to do in these specific census tracts that have the greatest disparities around the issues that Joey sort of laid out from the comprehensive plan. So just beginning to, I like the idea of having representatives from the mayor's office or potentially even this group on any external partner committees that might be addressing those items from the comprehensive plan. And I also, would like to hear what is the city already thinking around, those issues in those particular areas. And so that's just one idea for sort of next steps in addressing the disparities in the city.
I see our Recreation Director, Lori Yarborough on. Lori.
Hey, Councilmember Shealy. Dr. Richardson, great comments. So Parks and Recreation, I'll speak for our Parks Department as well. We've just finished with City Council's backing a pretty thorough Parks and Rec master plan. And it has certainly told us the same things that your map just showed. Where we have a deficit in Parks and Rec facilities, where we have a deficit in participation in city-sponsored programs is in those same areas of Joey's tracks and graphs. So it's very obvious that those two things are linked. And so I think that as we move forward, and I know Councilmember Shealy is not only chairing this valuable committee, he's also chairing the Standing Rec Committee. I know that's an area he's looking at is where do we start with those policies and help? Obviously, we have Parks and Recreation needs citywide, but when you look at 29405 and up in the neck area and those kind of things, it certainly plays into the longevity issues for life and some of the health disparities. So we have that already there. And so we'd be happy to talk about that. Dr. Richardson, if that would be of help.
Very good. Thank you, Lori. I appreciate that. And Councilmember Parker is also on that Recreation Committee, so we're very excited to have her on there as well. And and I know that Lori and Jason will be talking a little bit tomorrow with some people about that plan, and we'll have our Recreation Committee meeting on Monday as well. So very good. So thank you.
May I add something?
Yeah, Jennifer, please.
Yeah, so that was great information. And I wanted to kind of add to what Andy was talking about, because with suicide, I just emailed Paul yesterday. There was some new research put out by the Office of Suicide Prevention with DMH and USC School of Medicine. And I do think education around this is really important. Charleston was #1 in all 46 counties for suicidal ideation. For the suicide, for the rate. So it was like 65.5 out of every 10,000. We were #3 in numbers for suicide attempts. And, there's been things in the news about, EMS calls have gone up 40% for self-harm calls. But in Charleston, I think it was 85% from 2020 to 2021 for self-harm calls. So I like to be the best at stuff, and I don't like to be the top of the suicide list. But yeah, so I think, and I offered Paul, I could get our DMH suicide prevention folks or myself to present some of this data to you all. But I do think it's an educational campaign, and people need to know, and they need to know where their resources are. MUSC, us, everybody, anybody to help them. But it's pretty shocking data. So I do think that's really important.
Thank you.
Mrs. Roberts. Oh, I'm sorry, Mrs. Roberts. Will that data include, showing any rise because of the pandemic, because of COVID-19, or will all of these numbers be lumped together?
It's kind of lumped together because suicide data takes a couple years to get out. So it's like 2016 to 2020. So it won't really show as much of the pandemic because it'll take a little bit to get that out. But it's hot off the press data though, and it's pretty shocking.
Yeah.
happy to add something from the Low Country Food Bank if it's helpful as well.
Please, Nick, thank you.
Yeah, no, I think, Paul, as you mentioned, in terms of food access, and obviously we work with a number of different partners, partner food pantries, and those can be found. We have access to where those can be found on our website. There's a Find a Food Pantry, and that's clearly indicated in terms of addresses, but also on a map as well with contact data. So that's certainly something that's easily accessible, and certainly can look at ways and means in which we can share that more broadly, so that can be accessed. But that's some very clear information in terms of where food could be found at a variety of different pantries throughout Charleston. So in terms of access to food. I mean, the other thought that I'm thinking about as well is, how much does this overlay in terms of levels of poverty in different census tract areas as well? And when we talk about issues of, to your percentages, Joey, when we talk about the large percentage of factors associated to sort of social individual behavior, and how much is that linked to poverty? And how is that therefore linked more broadly to other broader opportunities in terms of economic opportunities, in terms of employment opportunities? When we think about transport as well, how transport networks enabling people to be able to access employment opportunities, to be able to have a guaranteed and secure income that enables people to have access to services like food and healthcare, etc. So it's a bit complicated, I know, but sort of looking at those overlays, that it's also, how do people address some of the problems that they have associated with the reasons why they're in poverty, and therefore largely around economic opportunities and employment opportunities to be able to ensure that you have a living wage that enables you to earn an income to be able to meet those needs both individually but also within households as well. So the importance of connecting with other service level providers, whether it be through access to training opportunities, education opportunities, but also more broader economic opportunities and economic development and areas of investment to support economic development.
Anything else on this topic, or any further questions for Joey? Any further comments, Joey?
Hi, Kevin. This is Susan Johnson.
Oh, yeah, Susan.
Hey, sorry, I'm in the car, but I just wanted to remind our committee that, we kind of started this work around the health and all policy strategy that we presented to City Council and was accepted. So we, our initial, I think, objective initially, we wanted to make sure that the health and all policies strategy was adopted and represented in the city comprehensive plan, which we were successful. And I think as we consider how to prioritize our work, that we want to make sure that we are aligned with those bullets. And I wasn't able to see Joey's slides, but I know he did pull some of that out. But we were very successful in that was into the comprehensive plan, and then our next step should be to now how do we impact those goals. I just wanted to throw that out.
Okay. Yeah. All right.
Yeah. So in general, I would say that, supporting existing programs through partners who are working to address these various health issues is one thing that we can do. And then we can also look to some unique things that we as a group have the ability to do, which is to recommend policies or ordinances or changes that we might want to see made, or things added from a policy level to our city council. And so that's kind of the unique position that we are in in this group. And so one thing we don't want to miss taking an advantage of.
Okay. All right. Very good. Anything else on this? Oh, go ahead. Oh, sorry.
So Kevin, I just think some next steps that we wanted to just get us back in front of everybody. And I think what we could do is to have a special, maybe we'll have a special committee with the health and all policies regroup.
Okay.
take these zip codes and look at some of these pocket areas in each community and try to identify what are the specific metric areas that we could look at around those areas that focus on the food deserts, the access to healthcare and built environment, and try to pull out what impacts or health disparities we're seeing in those, so we could get some bottom line metrics to do. And at the same time, working simultaneous with that, I'll get a memo out to our city departments just to ask them for some impact around those areas, what they're working on, and any programs or things, whether it's housing or economic development, whatever is going on in those areas, transportation that's been worked on. So I can just compile that list at the same time for you. And then finally, we can come back with some recommendations. But I do think one of the things we had talked about 3 years ago, when the pandemic hit us, we were about ready to have a little symposium to start talking about health and all policies and inviting, we needed these stakeholders from these communities at the table with us. So maybe between department heads and our stakeholders, we could all at least then begin that conversation with the expertise that's on this commission, as well as in our other areas, our advisory committee here. I think then we at least can start narrowing down what those metrics are and how each group is going to work toward improving those metrics. But whether it's working on diabetes, whether it's the access to healthcare, which is working with transportation, connectivity, whether it's the food deserts, are there policies that could we put in place to try to attract or make it accessible more, sort of leading into what Nick said about where food access is and where we have vacancies, that we can, what kind of policies do we have to put in to try to move the needles to move the progress, let's get rid of the word needles, but move the word progress in those areas that we can really start to see a change in what we can do as a community. And that try to, the mayor's goal is to take these 60s and 70s and let's get them working toward the 80s in life expectancy. So we can't do it by just talking. We got to make sure that we know what we're measuring and how we're measuring it to make it happen. So I'll work on that. I keep saying I'm being aggressive, but this is Bridge Run Month, so I will put out a lot of memos. But and we'll try to get the health and all policies together that Susan is I think still chairing. But we'll get that group together, and anybody that would like to join in there, it's going to have to be a public meeting anyway. So we'll just put out a notice that we're having the meeting and invite you to join in if you'd like to learn more about the health and all policies and specifically the metrics. I think that's what we got to focus on, is every one of these items that we've talked about. We need to go back and see what are the chronic diseases or health disparities that we're really talking about in these communities, so that we understand, is it diabetes in this one community that's driving down, or is it suicide? Is it, what are the areas that are being hit the hardest? And so we know how to address them to really make a difference. There's not a one solution for any specific area. It's a combination of things. So we just need to understand all those, and we'll work on that over the next month or so. We do have Jennifer, we are going to do your suicide discussion in April, and try to bring in some of the discussions there so we can keep that on the focus of everything. But I just there's some things we can do real quickly to try to deal with it. It all focuses on really understanding what the metrics are telling what's going on in those communities, and then bringing those stakeholders and our departments and community partners like the Low Country Food Bank and like mental health and all the rest of y'all are out there, that we bring them to the table to start that discussion as to what do we really, are these metrics what we're really measuring, or is there something we're not knowing about in these communities? So I just thought I'd try to sum up what Joey said.
Thank you, Paul. I appreciate that very much. All right. Well, if there's nothing else on that agenda item, I'm going to move on. I'm actually going to ask Dr. Richardson if she would introduce Ashley Greene, who's a a data analysis analyst, I'm sorry, with DHEC. So Dr. Richardson, if you would introduce Ashley, I would appreciate it.
Absolutely. Thank you. Ashley has been a COVID-19 epidemiologist with us pretty much for most of the 2 years that the pandemic has been here in South Carolina. She came to us from MUSC and has a strong background in data analysis. So basically daily, she's been giving us reports as well as weekly exposure site reports. She's really been helping both DHEC and our external partners be able to understand where we have been during the pandemic, to be able to make decisions around testing and vaccine clinics, preventive measures, and sort of thing. And for our management team meeting last week, she put together a sort of pandemic in review for Low Country region. And I am happy to say that she was available to present it to us today. So Ashley, the floor is yours. Thanks for joining us. Ashley, I don't think we can hear you yet. I see you're unmuted, but we can't hear you. Is it just me or can others not hear Ashley also?
Yeah, we're not able to hear her.
Okay.
So I don't know. But I do see it.
Hi, good morning, everyone.
There we go. Thank you, Ashley. We can hear you
There
now.
we go. Well, great. Just a little bit of technical difficulties to get me started, right? A few more seconds to gather my nerves in. Good morning, everyone, and thank you so much for allowing me the opportunity to share some of the data that was collected throughout the Low Country's pandemic experience over the past 2 years. Okay.
Ashley, you're in presenter mode. Can you transfer it to the mode where we only see one slide at a time?
Oh, okay. Let me see here. What are we doing? What are we doing? What about that? Is that better?
That's perfect. Thank you.
Yeah, great.
Awesome. Okay, perfect. I like perfect. All right. So, really in thinking about what the COVID-19 experience has been here in the Low Country, I was quite tickled when I saw an image that was shared in a previous presentation that was delivered by Dr. Jane Kelly. She is the Assistant State Epidemiologist for DHEC. And in this picture, it depicts the parable of some blindfolded people and an elephant. And this would have been the first time that they'd come across this elephant. And so natural curiosity, of course, arose, and they began to explore and conceptualize what they believed this large mystery was by simply touching it. So as we can see here, each of the blindfolded people felt a different part of the elephant's body. And they only felt that one part, though. Then they went to describe what we can clearly see as a full picture, but that part that they had. So they went on to describe what we know as the elephant based on the evidence of their limited exposure. And as we can imagine, their descriptions were very far and very different from one another. The perceptions that ultimately came from them ultimately led to them making an inaccurate decision as to what they thought this big thing was. And so in my mind, when I saw this, I thought, perhaps if we think about all of the pieces as one, we put all the parts together and we removed blindfolds, those that we want to have and those that were involuntary, then we can see the full picture and the conclusions that are drawn and the decisions that are made would be more accurate. The emergence of COVID-19 is similar to when this elephant came to town. And so our perspectives, and derived from both feelings and facts, were and are still so critical to our decisions. And so as we seek to develop and facilitate plans that gets us closer to what our normalcy or regain normalcy, we must remember to gather the parts, those lessons learned, the elements of humanity from our experience, and those we have great hope will give us the optimal success that we're all looking for. What I hope is gained from today's presentation of the COVID-19 data is that we use the data to paint a picture and a full picture in order for us to maybe think about not only what we've experienced, but what we hope not to experience again and how we can plan from that. So sometimes in painting a picture, the best thing is just to show a picture. So Dr. Richardson, I must thank you for sharing this source with us. And this taps into the feelings and the facts. So when we remove our differences and every other factor and focus on what's in front of us, I think we can all agree on two things. None of us asked for this pandemic, and all of us would love to see it go away. What we must remember is that the pandemic is about people, all people everywhere. So today, in a few moments, I will do my best to connect the number to the people, and the data presented are people. So this image comes from a project called the Intimate Portraits of a Hospital COVID-19 Unit from a photojournalist turned nurse by Alan Hawes. And Alan Hawes is a registered nurse at MUSC. And Alan's quote is, "If the public was more educated and could see what was going on and feel some of those emotions that I hope my photos show, I felt like it would make a bigger difference." His work allows us to see the pandemic from inside the walls of the hospital setting and from the vantage point that we don't always get of those who have had the inpatient COVID experience. Let's take a look at some of the numbers, which are people. So over the past 2 years, momentous 2 years would be an understatement. We have had we're going to look at the Low Country's rearview mirror here. And this data is up to February the 19th. So I want to make sure I state that. And I also want to note that, our data is live data. And sometimes there are reporting delays and such. So it is subject to change. And I just want to make sure we put that out there. So we've had a total of 309,217 total cases, 3,198 total deaths, and a total case fatality rate of 1.03%. And these totals are a combined total of the confirmed and the probable cases. So the confirmed cases, as we can see in the larger table, have been 226,720, and the confirmed deaths have been 2,729 deaths. That is from the full pandemic since our first case was confirmed on March the 4th of 2020. On the county level, if we're going to take a look at the table here, we're going to look at it from apples to apples because we realize our counties have different sizes and populations. So in order for us to really get a good picture and to be able to compare the counties, we have to find a way to sort of equalize them. So if we looked at the numbers, for example, we might see Charleston County had 77,557 cases, and then we might compare that to Allendale, which had 1,744 cases. We also see that there's a huge population difference there. So we can put like 47 Allendales inside of Charleston population-wise. But when we compare them by 100,000 population, what we see is that Allendale had more cases per 100,000 than Charleston. So that's why we look at it we call that per capita to help us get a better way to compare counties to other counties. So from a per capita perspective, Orangeburg County had the highest cases per 100,000 at 22,404 cases per 100,000, and Calhoun County had the lowest at 1,289 cases per 100,000. Right next to it in red is the deaths per capita, and Colleton County had the highest which is 523 deaths per 100,000, and Beaufort County had the lowest at 161 deaths per 100,000. And just next to the column that has the deaths per 100,000 is the case fatality rate. Case fatality rate has not been a metric for decision making, but it certainly has been one that has been helpful in comparing like an indicator for outcomes and being able to compare counties in terms of death as an outcome within those counties. And that helps to highlight things like where we need areas, where the areas are for maybe increased testing or to promote earlier testing and vaccine uptake, so on and so forth. So just to sort of define case fatality rate though, case fatality rate is the number of people out of all of the people that have had COVID and been confirmed. It's the number of people that have died from COVID. So we're looking at the number of people who've died from COVID out of all of the people who've had COVID, and that's how we derive our case fatality rate. So when we look at our case fatality rate, Charleston County, has had the highest case fatality rate at 3.25, and Beaufort County has had the lowest case fatality rate at 0.89. And as a whole, if we want to look at all of the Low Country counties together, when we look at the cases per capita, we have 18,820 cases per 100,000, 227 deaths per 100,000, and the Low Country combined case fatality rate is 1.20. And I should point out here that when we have high case surges, like what we just recently experienced with the Omicron variant, this does impact the case fatality rate. So we might see the case fatality rate go down when we have the large surges of cases that come in, and then that case fatality rate, of course, just adjusts as the COVID-19 deaths are reported, and those deaths tend to lag for about 4 to 6 weeks after we see the cases be confirmed. So just want to make sure we put that out there. But what we will say is in our recent time period, the COVID-19 cases have significantly decreased since peaking about 6 weeks ago. And there is marked improvement in the Low Country pandemic situation. All right. So look, we're going to look at like riding the waves here. And so each of these waves, we've tried to identify them if they were associated with a variant surge. So we see the alpha wave, and we see the delta wave, and we see the Omicron variant wave that these are surges that we had experienced that just went, that occurred with a variant. And so this is an epi curve, which illustrates the confirmed cases for the full pandemic. And we're going to be looking at confirmed cases a little bit more closely. And that's because the definition and sometimes the meaningful use of the probable cases has changed and been updated throughout the course of the pandemic, but the confirmed definition is what is standard across the board. All right, so for if we're looking at 2020, and we're looking at the confirmed cases, so the confirmed cases is the 226,720. In 2020, we've had 59,105 cases, and that's 26% of the total number of cases that we've had from the beginning of the pandemic to February the 19th. In 2021, we've had 98,669 cases that were confirmed, which is 44% of the cases. And we're just at the beginning of March, and we talked about the data coming from February. So in February, at the time that this data was generated, we had already seen 68,946 confirmed cases, which is 30%. So just within the first really month and a half in the new year, 2020, and we still have 10 months to go, 9.5 months to go, we've already seen 30% of the COVID-19 cases overall, 30% from the overall. It should be noted that, you know, as time progressed, we saw that the waves, they didn't get smaller. Those surges got higher, but how we responded to them, you know, that also changed over time, and it is evolving. It continues to evolve, even though we've seen higher case numbers, and that has to do with like the severity of the disease and decision making that follows the trends of the data. So we'll take a look at that. I do want to point out that at the top here, there's 3,507. And what that represents is that's our highest peak of cases that were confirmed within one day. In some cases, this is more than what we've experienced in some of our weeks. So that just helps to give an idea of just the magnitude of cases that were confirmed during the Omicron surge. Then we're going to look at cases per week. And when we look at cases per week, our weeks start on Sunday and end on Saturday, and that's the way that the CDC looks at their cases by week as well. And what we'll see if we look at cases by week, that gold bar is where we were on the week of the 19th. And what we'll see is that the cases that are associated with the Omicron surge are declining. And, you know, of course, we're all cautiously optimistic about the trajectory that we're currently on. And what we must note is that we should remain vigilant in doing all we can to continue in this downward direction. There's a couple of areas that we should talk about with this slide, and that is with each of these surges, as we said, that the peaks got higher. We also got to look at, when we look at the waves, we want to look at the size of the waves. If we were to compare the size of this surge wave that falls under the Omicron variant, and we compare it to, let's say, the size of the wave that occurred with the Delta variant or the Alpha variant, what we'll see is that we had a steep climb from the beginning of that surge to when we reached our peak point. And then we had a steep decline that from when cases started to decline. And that means that we've had a surge and we've seen a lot of cases. That speaks to the increased infectivity of the variant. But the length or the duration of the surge was shorter than what was experienced in the Delta variant and what was experienced during the Alpha variant surge. What we also want to make sure we are mindful of is the burden that sometimes is placed, well, the burden on the workforce. And the impacts that it has here. So in higher cases, particularly in the healthcare profession, we've seen, you know, increased work burden, especially when it comes to turnaround time for hiring and onboarding staff to address specific aspects of the surges. And, you know, with short durations between the peaks or short durations, maybe in the surge experience, that's been a challenge to get everyone hired and trained and being able to function independently and keep up with the requirements of not only the daily operations that we have, but also addressing the surge that we've seen. But we want to compare the previous week to that current week, sort of bringing it a little bit closer to where we are now. We'll see that there was a 45.5% decrease in the weekly cases. It should be also noted that there's been a decrease in the testing rates. also want to make sure I don't want to miss anything. That's for sure. Well, we want to say when we talk about that 45.5%, if we were looking at it in terms of numbers, that would equate to 1,184 weekly cases. That makes up the difference there. The 7-day average is a metric that's been used for decision making. So from the highest 7-day average that we've seen during that peak period of the Omicron variant, which was 2,673 cases, to where we were at the gold bar in February, to an average of 202 cases, there's a difference of 92.3%. So that's pretty significant. And there is a 45.7% decrease in the 7-day average between the two most recent weeks, illustrated on this slide.
Ashley,
Also,
we just have a couple more minutes if, and I apologize. I know we went along on the agenda item before you, but if we can kind of narrow it down a little bit, I would appreciate it. So.
Oh, absolutely. Absolutely. And I'll make sure that the slide deck is available, and we're always available. So if you have any questions or any concerns that, that you would like to discuss with us, we're always there to do that. And then also we're always available to make any sort of specialized reports for you.
Yeah. Well, thank you. And Paul will certainly share your information with one as well too. So thank you. Sure. So that's a epi curve of the deaths. And of course, if we wanted to look at the deaths, we will see that 109 was at our peak. And for our most recent Omicron variant surge, we at this point had 82 deaths per week. And those do come in, like we said, late, depending on coroner report and vital statistic reports and so on. We did briefly just mention the impact that it does have on the healthcare system. What we will say is while we have, and why this is important is when we talk about hospital occupancy, it's our ability to treat everybody. It's not just the ability to treat COVID patients. So when we talked about increases in hospital occupancy, it's important for us to remember that that's what is being used for all of those patients, and then what's available for all of those patients that may come in that require inpatient services, and whether or not we have staffing available for that. Vaccination still is our leading public health COVID-19 prevention strategy. So we definitely want to still promote vaccination. The Low Country is, when it comes to completed COVID-19 vaccinations, we're doing a bit better than the overall vaccination percentage here for the state. At this time, we had 13.6% of South Carolina children 5 to 11 that had been completely vaccinated. So still a large area for improvement out of all of the children that are eligible for vaccination that could be vaccinated. As we have probably become all aware, there is emerging updates being made to our guidance and recommendations. And the CDC has been briefing us on how at this point the guidance has changed and how they're going to be, the method that they're going to be using to sort of gauge our COVID-19 pandemic experience at the time. And the positive is that we're not locked into one way or another. Built into those plans are opportunities for us to re-engage and uptake public health mitigation measures should we see increases present themselves. And some of those metrics that they're going to be looking at is what's happening in the hospital system, and the severity of disease is going to be very important for how we manage during those times. But this is valuable for us at this time because it does allow us to give a very fatigued community an opportunity to return to some normalcy while we can and during this period of time. So I certainly appreciate having the opportunity to share this with you. Like we said, we're still here. We're still open to speaking with any of your groups and providing specialized reports. Certainly there is no text without context. So if we want to have deeper conversations that talk about things like equity and how we can sort of target certain populations that have had a particularly
bore a disproportionate burden during the pandemic. We're certainly always available and willing to do so. Here is our contact information, Dr. Errol O'Connor and myself. Please feel free to reach out to either of us, and we're happy to assist. And we thank you for all that you do for our communities and the role that you play in helping to save lives. Thank you.
Thank you so much, Ashley. Great presentation. We appreciate you putting the work into that and sharing that with us. I guess I'm going to turn it back over to Dr. Richardson to see if she has any further reports now.
Yeah, I think Ashley ended by mentioning the new CDC guidance and DHEC. Everyone just received that on Monday of this week. And so DHEC is processing that and working on putting out South Carolina specific documents around those 3 new metrics. And that's new cases per capita over the last 7 days, and then 2 related to hospitalizations, new COVID-19 admissions per capita, and the percent of staffed inpatient beds occupied by COVID-19 patients. That data is already, it will come out from the CDC every Thursday. So the map that looks by county and divides up into 3 indicators, low, medium, and high. Charleston County, this is the first week it's been provided, is in the medium risk group. So I think I'll stop there just in the interest of time. I'm happy to take questions now, or feel free to reach out to me after this meeting. Thank you.
Thank you, Dr. Richardson. Any questions?
I do have some questions, unless someone else wants to go first.
No, please go ahead. Thanks.
Okay, so I appreciated that elephant picture and the whole picture idea, but that's the one thing with some of this data, it's always seems to be missing some pieces, like confirmed cases and fatalities. Do you have the data, vaccinated versus unvaccinated? How many of those were hospitalized, treatments given, anything like that, Mrs. Greene?
I can address that. So okay. I mean, we didn't provide that in the presentation. We're trying to keep it short and sweet to get it in and allow everyone to give feedback. But we certainly have numbers of total hospitalizations as deaths in the Low Country region. DHEC on the website does put out monthly of those who have died, what percentage were vaccinated, what percentage have had other chronic diseases. And so we do have data that we can sort of slice and dice lots of different ways. We present a ton of that on the DHEC website, but if there's anything specific that you'd like us to look at, we're happy to do that as well.
Well, I just think it's important when we're talking about the big picture is sharing that information with the public.
So some of it is on the website, and if there's something that's not on the website you'd like to see, I'm happy to look at it for you.
Okay, and you said that some of that data will also include how many deaths had multiple comorbidities or other,
Correct. That is a monthly report on our website, and if you have it, just let me know, and I'm happy to lead you to it.
Okay. And obviously, so one other thing, I just noticed, and I'm not a health professional or anything, but just looking at the map, looking at the mountains, the wave of Omicron. I mean, I know Mrs. Greene said it, but we had immense amounts of forced testing, tests being inaccurate. And we also had fraudulent testing sites. I mean, I just feel like those type of things aren't really mentioned in those surges, and a lot of people who are making decisions surrounding this are looking at this one metric, seeing this huge rise. But I don't feel like a lot of that is ever mentioned.
I mean, no test is perfect. I think these tests are actually very good in general, both the PCR and the antigen test. I do think that they look at slightly different things, and we can certainly, talk more about that. But I do think that the tests are generally accurate. Certainly that is true with the number of tests done across the nation. There is going to be some very small percentage of vendors who, take advantage of the system. But I think that at least in South Carolina, which is what I can speak to, I think that is a minuscule number of the tests that were done. Certainly everything that's been pointed out to DHEC that may have been fraudulent has been corrected.
So they removed those numbers?
Right. So if for some reason there was a positive that might have been reported incorrectly, when it is corrected, when we pull this historic data, those numbers are corrected then in this data that we would have presented today, for instance.
Gotcha. And just again, just a mention of, the increase in forced testing, especially in that one graph showing, I think it was Delta to Omicron, the huge jump. Clearly there's a metric that certain organizations, whether it's school district, city, county, whatever it is, to forced testing. I think that that's an important data point when we see a huge spike like that. But again, I'm not a data girl and I'm not in the medical profession, but when we're talking about whole picture, elephant, I think those things are important.
I certainly think the testing has risen with each of our surges as the community has had more symptoms and been concerned about their health and gone in for testing. Certainly some organizations and schools have decided that whether it's screening testing or testing for symptoms to return to school was the best thing to keep their community safe. That has certainly happened. What we're seeing is we're really moving away from PCR testing to at-home testing. That testing is not reported to DHEC, and that is part of the reason for moving to these more community metrics, looking at hospitalizations rather than total numbers of tests because of how the testing is evolving here in the state and across the nation.
Okay, and I would love to see the vaccinated versus unvaccinated. I mean, I get that this is a big part of the Health and Wellness Committee. I mean, but I'm still a little confused. But obviously, not to go on a tangent. I mean, these metrics are certainly what our HR department, our mayor, whatever, are looking at, for our employees. So that's why it's really important that I am looking at, obviously vaccinated versus unvaccinated, because like you said, y'all are headed towards the at-home test, but our city is not allowing our employees to do so. So these type of metrics and numbers, I think, are really important to have that big picture conversation because, we're implementing strategies and, these aren't really inclusive decisions for looking at the big picture if we're not including those type of metrics.
I'm happy to provide you any information you'd like. You can just reach out to me through Paul after this call. But as I said, the vaccinated versus unvaccinated, I think there's lots of data that those who are unvaccinated are suffering more of the severe consequences, both hospitalizations and deaths, if you're talking about the individual. And then, as I said, on our website, we do have monthly the percentage of those who are hospitalized and who have died based on whether they're vaccinated or unvaccinated and the comorbidities that they may have had.
All right. Well, thank you. Thank you both for that. Appreciate it. And before we leave, is there any community? I know we come to the end a lot and we don't have time for the community updates a lot, but is there anything out there that we need to share as far as community updates? All right. And I'll share this little link that I just shared with everybody, but I know Alan Hawes was brought up. There's a great news story. Most of you have probably seen it, especially those that are connected with MUSC, but I think it was David Begnaud and Aisha Tyler did a great presentation on what was going on inside MUSC. So I sent that link, or you can go to live5news.com, put in Alan Hawes and in the search, and you can find that. But a very interesting news story and COVID patients. So, all right. Paul, is there anything else that we need to? Oh, I do want to ask one question on here before we go. We don't have everybody on here, but I wanted to kind of get a sense of whether we wanted to stay with our Zoom meetings or whether we want to go back to meeting in person. Does anybody have an opinion on that and where we are with that?
Zoom is more convenient for me.
Okay, well, if Zoom's more convenient, that's great. That'll be fine. We can continue with that. Maybe we even go with a hybrid type situation if we want to in the future, but I kind of just wanted to get a feeling from everyone. So I apologize that we ran over. A lot of great information, great meeting, and I appreciate, as always, everybody's time. I know your time is very valuable, and we appreciate you giving your time to this committee. It helps us a bunch. So if there's nothing else for the good of this committee, I'm going to call us adjourned. But thank you so much.